The broadcast is now starting. All attendees are in listen-only mode.
Thank you. I'd like to invite my friend and colleague, Dr. Klaus Pirak, to come up for a minute. Many of you know Klaus is an internal medicine physician who's had a long association with Abbott Northwestern Hospital and was a close friend of Howard Burchell and has many stories about Howard, but I think to give a flavor for the human being, and Klaus does that so well, I'm going to ask him to say a few words, and then I'll introduce Dr. Harrington.
Thank you, Scott. First of all, I would like to express my deep gratitude to the Minneapolis Heart Institute Foundation, to Abbott Northwestern and Alina for continuing this lectureship that we started 15 years ago and which has been carried for the last few years by Scott Sharkey and Tim Henry. I'm grateful to both of you and all of you who continue to honor the memory and remembrance of Howard Burchell. We started 15 years ago when Dr. Burchell was still alive because we wanted him to see how much we revered and cherished his contribution, not only to cardiology, but to medicine at large. Dr. Burchell, as many of you know, was born in Canada, was trained in Canada, in Toronto, and here in the United States, but also in England at the Heart Hospital in London. After the war, after he served in the war, he came back and was at the Mayo Clinic, and in 1968 came up here, was recruited and appointed a professor of medicine, and was the first one to chair the division of cardiology at the university, a job and a profession that he really, truly enjoyed, and I think his imprint is still felt at the university. In 1975, after he retired at the university, we were very, very fortunate to have him come down and reside here at Abbott Northwestern Hospital, where he became an integral part of our teaching program, which was started in '66 by Dr. C.J. Watson. Dr. Burchell was, and I think I speak for many of you, was practicing a cardiology from a holistic, patient-oriented standpoint. He was really, truly a cardiologist practicing primary care, which is not an oxymoron. It can be done and is done, and I'm delighted to say that I sense the same attitude in many members of the Minneapolis Heart Institute. Dr. Burchell was actually fun to go on rounds with him, and he enjoyed it and we enjoyed it, and he showed us how to let the patient know that the patient is our focus of interest. He would often hold the patient's hand while he was talking to the patient. He would put his hand on the patient's shoulder, and in the end, when we were done seeing and examining the patient, he would straighten out the patient's pillow or say, "Is there anything else I can do for you?" And often enough, a smile was seen on the patient, on Dr. Burchell, and on many of us. I'm delighted that today we continue with another August speaker in Dr. Harrington, and Scott Sharkey will introduce him. Thank you.
Thank you, Klaus, very much. Bob Harrington comes to us from Stanford University. He was kind enough to come in a day early and have dinner with us last night. We had a grand time and kept the place going until late. Bob is the Arthur L. Bloomfield Professor of Medicine at Stanford University, and he's the chair of the Department of Medicine at Stanford. Bob hails from Boston, Massachusetts. He's a graduate of Tufts University School of Medicine, and also the University of Massachusetts. Worcester was where he did his internal medicine residency and was the chief resident there, and then after that went to Duke to become a fellow in cardiology, and climbed the ranks at Duke University and became the director of the Duke Clinical Research Institute in 2006, at which time he carried that through until 2012. He left Duke University as a distinguished Richard Stack professor and was recruited to Stanford in his current position, where he's been since 2012. Bob has authored more than 500 manuscripts and book chapters. He's a senior editor of the Hearst the Heart book, which we all have used in our careers. He is associate editor of the JAMA Cardiology, and he is on the FDA panel for cardiovascular and renal drugs. He's the chairman of that panel. And I could actually go on and on and on, but then that would cut into his talk. So Bob, please welcome to Minneapolis and to the Minneapolis Heart Institute and to the virtual lecture. Thank you.
Well, thank you, Scott, and thank you to my friend Tim Henry for inviting me. It's a really special honor. I think these events where we honor the past and try to remember the lessons that we learned from some of the great physicians that came before us, I think are really important. And I had a really wonderful dinner with the group last night. Let's see if I get my slides going here. Got it. So first off, I want to remind everybody today's opening day. And so I root for your favorite baseball team. This is my front yard in California. There were several, because Tim brought it up, I do live in a winery. And that's one of the benefits of moving from North Carolina to the mountains outside of Palo Alto. But I still passionately root for the Red Sox, not the Giants. And so a new flag has been hung up to get the new season going. And last night I had the real privilege of being with the group to think about Dr. Burchill and heard terrific stories about his the way that he led, the way that he interacted with patients, and maybe most importantly and most interesting was the way that he interacted with his younger colleagues. And Tim Henry fondly recounted, maybe not so fondly recounted, he had handwritten notes pointing out the corrections in his manuscripts that he had recently published. And as I thought about Dr. Burchill and learned about both he as an individual and as a medical leader, I included a couple more slides to just help me reflect on the day. The first of which is that I understand that he had four daughters. Let's see if I get this going here. And I have four daughters, so I thought that I would add for Dr. Burchill's friends to from his four daughters to my four daughters. There they are with my wife at Christmas time. And then the other thing I thought I'd add is that as I heard the stories of Dr. Burchill, it made me think deeply about someone who had a profound influence on many of us at Duke University, and that was Gene Stead. I also think that they were probably contemporaries in terms of when Stead was the longtime chair of medicine at Duke. And Stead really had a number of great accomplishments, but maybe the two that resonate with me the most and for which I had the privilege of interacting with him the most until he passed away at almost age 100, about 10 or 12 years ago now, is that he is the founder of the Duke Databank for Cardiovascular Diseases, and that's the research group that ultimately went on to become the Duke Clinical Research Institute. And so many of us who were trained in the Duke Databank back during our fellowships owe a real debt of gratitude to Dr. Stead. And the second thing he did was he's the founder of the physician assistant profession. And if there are any physician assistants in the room, you'll note that October 6th, which is National PA Day, that's Dr. Stead's birthday. And it's celebrated every year, and it makes us think about Dr. Stead with one of those seminal contributions. And when I am going to give a talk where it's going to be a lot of technology involved in the discussions here, I'm always reminded that whenever I think I'm doing something new and interesting and creative, and I go back and start to research it, I realize that Dr. Stead actually thought about it 40 or 50 years ago. And I suspect that when you think of certain things, you realize that Dr. Burchill thought of it many decades ago. This was a paper that Stead wrote in 1972. He said, chronic multifactorial disease problems can be studied, but not by the methods of the present or the past. If one wishes to create useful information, computer technology must be exploited. 1972. That sounds pretty good today. And so what we're going to do is talk about this notion of rethinking randomized clinical trials. And I have a number of topics that I want to go through with you. We're going to talk about demands of evidence, some of the limitations and challenges of the way that we currently do randomized clinical trials. And then I'm going to try to get you excited and interested in thinking about some of the new ways of doing research, some of the new ways of dealing with large-scale data. And so we'll talk about new sources of data, new methods of getting data, doing analyses, new patients, and new partners in the whole notion of patient centricity is really partners, our patients becoming our partners in the research process. And I'm going to give you a series of examples that both we and others were involved with to try to show you how, in fact, trials can be done bigger, faster, cheaper, and better. And then we'll end with at least some mentioning of issues that I think, if the clinical research process is really going to change, we as a community have to really grapple with. And that is, number one, the ethical construct of trials. The way we currently do trials reflects an ethical construct that goes back to the post-World War II era. And for obvious reasons, from that era, trials evolved in a certain way. But the question that really arises from an ethical perspective is, that's still the right way today? And we'll briefly touch upon the notion of open data and science sharing. So first off, the whole notion of sharing evidence, of why we need evidence in society. And we need evidence because there's a demand for it both to practice medicine and to deal with policy issues. And so increasingly, people are making decisions on how they do things like pay us, grade our system, increase or decrease our reimbursement on a variety of quality measures which are only available to them through the construct of clinical investigation. Likewise, at the more macro level, we have regulatory approvals, reimbursement policies, and the emergence of comparative effectiveness research, all of which are highly tied to this notion of being able to do high-quality clinical investigation. And the reason, though, that my slide doesn't say rethinking clinical research, but rethinking clinical trials, is that if we're going to talk about treatments or strategies of testing, of diagnostic testing, you really need to think about randomization. Because while there's power in observation, there's power in outcomes-based research. If you really want to understand one thing relative to another, how does A compare to B, B compare to C, et cetera, there is really no substitute, at least right now, for randomization. Back more than 20 years ago now, Richard Pito of the ISIS group said regarding large-scale randomized evidence that there's simply no serious scientific alternative to the generation of large-scale randomized evidence. And what he was really referring to, remember, this was on the heels of the thrombolytic trials, where we did enormously large trials through GC, ISIS, Gusto, to try to understand important but relatively modest differences in outcome comparing one thing versus another. The original Gusto 1 study, 40,000 patients comparing 4 different regimens of fibrinolytic strategy to show a 15% difference in mortality between or among the regimens, and really demonstrating the importance of this whole notion of opening up an artery quicker was really what was the key fact associated with better clinical outcomes. And the only way we're really going to know that and be able to tease out these modest incremental gains in clinical medicine is through randomization of large-scale evidence. So we're going to talk more about that. The problem that we've arrived at is what's seen on this slide here. And I suspect many of us have been involved in clinical trials like this. Randomized, double-blind, involving over 20,000 patients, conducted over a 10-year period. Unfortunately, we've forgotten why. And this is a problem. And this is cartoonish, but it's cartoonish because, in fact, it's all too real. Now, I usually will only pick on trials that I've been involved with, so I'll do that for the next couple to point out some of the limitations and challenges here. So many of you know the Improve It trial, which looked at the adding of ezetimibe to statin therapy and comparing it with statin therapy alone. Pretty simple question. Lowering LDL with statins among patients with known coronary artery disease improves clinical outcomes. Lowering cholesterol, LDL cholesterol to about 70 with high-intensity statins seems better than lowering LDL to around 100. If you add ezetimibe to a statin, you get this additional LDL lowering. Is that better? Pretty simple question. Took us over 10 years to actually answer that question. And why was that? Look at the work that went into this to answer the simple question. Lowering cholesterol from 70, an LDL of 70 to an LDL of about 55. This is what it took to do. 10 years, 33 investigator meetings, almost 15,000 clinical events adjudicated, 15,000 SAEs processed, 30,000 monitoring visits, etc. This is not sustainable as a society to answer important clinical questions that we need to know the answer to. And it's not just the industry highly regulated by the FDA that goes through this process. NIH trials are not immune from this, particularly NIH trials that are answering big, important clinical questions. The ischemia trial, another trial that we're involved with, where the data coordinating center is in my former research group, and it's led now by Judy Hockman of NYU and David Marin of Stanford, is a pretty simple question. You've got patients with moderate amount of ischemia, with angina. Do you randomize them to go to the you randomize them to either go to the cath lab with a revascularization strategy based on anatomy, or you follow them on medical therapy and utilize the cath lab only if they truly fail medical therapy? Not a very difficult concept to understand. It challenges a fundamental tenet of contemporary cardiology about the use of the cath lab and revascularization. There's a lot of these patients. 8,000 patients was the original sample size. It's been downgraded to 5,000 because the event rates are higher than we anticipated, and because the enrollment has been going on so long. This trial is going to take us 8 to 9 years to answer the question. And to me, that's not acceptable. Now, it doesn't quite cost the amount of money that something like IMPROVE-IT costs. The budget for this trial is about $125 million of all of our taxpayers' money. But that's going to take us 8 years to answer a question when there are hundreds of thousands of these patients, if not millions of these patients, coming through the U.S. system every year. And so we can ask ourselves, why is that? And what can we do about it? Several years ago, Rob Califf and I compared clinical research in the United States to the textile industry in North Carolina. The textile industry in North Carolina got outpriced. And when it got outpriced, it got moved offshore. And it devastated large portions of the economy in North Carolina. And this particular editorial accompanied a report from the NHLBI pointing out that more than a third of the patients now enrolled in NHLBI, U.S. taxpayer-sponsored trials, were now being enrolled outside the United States because we had insufficient ability in the United States to carry out those studies. And we raised the question of whether this was one of a number of reports that raised the question of whether American clinical research, like so many other U.S. industries, has become so expensive and inefficient that it is no longer a viable competitive enterprise within our borders. That's a troubling statement, and we're in trouble if that's going to continue down the path. I think, however, that in light of what Gene Stead said many decades ago, that we do have some new opportunities here. And we largely have new opportunities because of what you see on the slide here. Our ability to amass large-scale data and then to turn that data into useful information is at an unprecedented time. Over the last couple of years, our ability through cloud computing, advanced analytics, artificial intelligence, machine learning, deep learning, all of that has made our ability to collect, to aggregate, to share, and to analyze something that's completely unprecedented at the speed at which we're going in healthcare. If you hear the phrase big data all the time, I won't go through a description of it, but if you're interested in the topic, this is really a terrific book that goes through sort of the background information on what is big data and how might you think about it, not just in healthcare, but virtually in anything we do. Well, at Stanford, we've been involved in a massive outcomes project around the globe, led by one of our informaticians, Nigam Shah, trying to understand, first off, how do you bring massive amounts of information together? So this is a project involving 12 to 15 health systems around the globe who have agreed to allow access in an aggregated way to all of their data. So now analyses are possible on north of 200 million individuals. And the first paper that they've published from here is pure description, just to see from a technical point of view, can you analyze 200 million patients, and can you extract useful information from that 200 million individuals? And in fact, what they try to show here was how people think about diabetes treatment in patients with type 2 diabetes. And what you can see is that if you're trying to understand sequencing of anti-diabetic medications, it actually makes very little sense. It certainly is not following the guidelines. And the only thing that makes sense is that the largest color that you see up there is metformin. And so overwhelmingly around the globe, there is a backbone of metformin use as the inner circle, the first level of anti-diabetic strategy. But after that, the colors are all over the place because people are using very different strategies. So there's two things at play here. One of which is just through observation, we can begin to better understand what people are actually doing in practice, which helps inform clinical trials that might come. But then ultimately, how do we do clinical trials within massive data systems like this so that rather than people making choices about which therapy is going to be choice 2 or choice 3, that randomization can take place within the system and allow us to get a more systematic approach to understanding choices in diabetes therapy. Many of you know Eric Topol. He's written a series of books. This is the second one. The first was The Creative Destruction of Medicine. The second, The Patient Will See You Now, really gets into this issue of how we as a profession need to better align ourselves with the needs of our patients, particularly as it starts to get into the issues of data accumulation and data sharing. The notion of patients coming to see us, driving for an hour to see us, waiting in a waiting room for a half hour to a couple of hours to see us, seeing us for 15 minutes, and then leaving is a very old-fashioned view of the world. And how can we utilize new tools to get information in a more continuous basis? And then ultimately, how do we do research in this construct? Well, I'll show you some examples that we've been working on. This is the launch of the Apple iResearch Kit 2 years ago at the Apple Spring Forward event. This is Jeff Williams, the Apple COO, announcing that Stanford and Oxford would partner on the first application on the iPhone to do research in cardiovascular disease. It is called My Heart Counts. And many of you may recall it was launched during the American College of Cardiology meetings, and in the first 24 hours that it was available on the web, we got 11,000 individuals to download the application to give us informed consent to collect their health-related data. So think about that. I just told you it took us 10 years to do the Improve It study. It's going to take us about 7 or 8 years to do the ischemia trial. And we enrolled 11,000 patients in 24 hours, so 11,000 subjects. Over the course of the first 6 months, about 50,000 patients gave us their informed consent. And one of the things that this points out is some of the challenges that if there are any study coordinators in the audience, you know this, the complexity of informed consent has really become a legal document instead of what it was intended to be, which is an ability to share information about a research protocol with a potential patient or subject. And so this utilizes a very friendly series of steps to get people to understand what they're agreeing to do and to move through the consent process, I think, in a much more reasonable way. It also allows them to opt in and opt out at any time of what part of their data they want to provide us. And with this, there are audit trails about when they opt in, when they opt out. And so we can begin to also give people the options. Maybe they don't want to give you all of their data, but they're willing to give you most of that data. So just a couple months ago, we published the first paper in JAMA Cardiology on about 48,000 patients and really trying to demonstrate the power of this as a data collection tool and as potentially setting up the substrate to do randomized clinical trials. And in fact, we're now doing randomized clinical trials within the iPhone, within the application. And if any of you want to participate in a randomized clinical trial, you can download My Heart Counts from the Apple Store for free. You can give us consent, and we'll get you into one of the clinical trials that we're going to do. But we're doing clinical trials. The first clinical trial, as you might imagine, as a feasibility, is going to test a rather straightforward intervention. We're going to be testing different methods of lifestyle coaching in order to see if we can increase physical activity. Turns out that we have very good data now using the iPhone as an accelerometer and our ability to count steps, count distances traveled, etc. And so there's ways of measuring how your activity level might improve. And so we've just launched that. The second thing we've just launched is a partnership with 23andMe, where in addition to allowing you to contribute your data through the application, you can also donate your genetic data through 23andMe under protected research circumstances for your genetic data to be paired with your clinical data in these kind of experiments. So this is live and underway. We've enrolled, I think a week ago, about 2,000 subjects in this lifestyle intervention trial, and you'll note that we only opened in January. So 2,000 patients over the first couple of months. This will get more and more sophisticated as we learn more from it, and we'll ultimately get to a point where we're doing pharmacologic interventions, technology interventions, a lot of different things that the technology makes possible. There's other ways of collecting large-scale data that allows not just insight into the biology of a particular population, but also begins to offer up the opportunity to embed research, including potentially embedding randomized clinical trials. We're involved. This is the President's PMI initiative, the VA Hospitals VA Hospitals Million Deaths Program. The AHA has One Brave Idea, a partnership with Verily, which was formerly Google Life Science, the Heart Association, AstraZeneca, and then we're involved with a project with our colleagues at Duke and with Google Verily called the Baseline Study. And what we're going to do in the Baseline Study is something that's actually pretty remarkable, that we are going to, on 10,000 subjects, 5,000 in North Carolina, 5,000 in Northern California, extensively characterize a group of subjects with cardiovascular disease, at risk for cardiovascular disease, or not at risk for cardiovascular disease, as well as common cancers, the same sort of cohort collection. And we are going to be doing about as deep a dive into their biology as you can imagine. Everything from physical examination to routine blood testing to the omics, imaging, exercise testing, wearable devices, sensors, etc. All of this information is going to create an amazing opportunity to understand, and we're going to follow these subjects for 5 years. It's going to provide an amazing amount of information to really, we think, rethink biology. What are the ways that you move from health to illness? What are the ways you move from illness to recurrent events? And can we understand it in a way that then will allow us to intervene? What's Google's interest in all of this is that every subject at every visit over 5 years will generate 4 terabytes worth of data. So think about those of you who had computers in the old days, how much data that is. 4 terabytes worth of data per subject per visit. And what we're really interested then is, can you take very disparate forms of data, imaging data, exercise data, omics data, and begin to draw inference around some of the risk characteristics, for example, for the development of cancer. First subject will be enrolled in first week in June. And if any of you traveling to Northern California would like to be enrolled, let us know. It takes, the first visit takes 14 hours and over 2 days. And so it's a very intense experience. Other ways of thinking about the collection of large-scale data starts to involve engaging our patient population. And so this is work from the Mayo Clinic, where addressing the issue of spontaneous coronary dissection, the actual first accumulation of the women who had experienced a spontaneous coronary dissection, or SCAD, came through social media. And it was through a social media group that the women who were involved with that social media group contacted investigators at Mayo Clinic to say, hey, shouldn't this be studied? Isn't there something here? And this, I would call, is a real movement towards patient centricity and beginning to force us to think about doing trials, not just the ones that we want to do or that we think important, but trials that the patients think are important, that are really germane to their diseases. And there's a lot of ways that people are doing this now. There's the website Patients Like Me, where there are now 500,000 patients who have contributed their data into a repository online called Patients Like Me, that now is partnering that patient group with pharmaceutical companies, with government sources, to do observational studies, but to also begin to do randomized clinical trials. And so a much different way of looking at how one does this. And you can see here using Facebook to recruit college-age men for an HPV vaccine trial. So different ways of beginning to think about doing clinical studies, I think, is a way to rethink randomized clinical trials. There's some amazing ways that people are beginning to collect data and do research. We published this paper in JAMA Cardiology a couple of months ago, commenting on an original investigation where someone was looking at Twitter as a potential data source for cardiovascular disease research. And this is still in the early days of trying to understand, well, what does this massive collection of data potentially mean? But this is where the world's going. Recruit patients through social media, even begin to think about social media as the data collection source is not tomorrow. It's here now. People are beginning to do this stuff. Interesting perspective piece appeared a couple weeks ago in PLOS Biology, which is commenting on this movement towards social media to recruit patients, to follow patients. And they asked the question, is there actually an ethical duty to tweet? That should your studies uniformly have a social media component to them? And what the article is about, what the viewpoint is about, is can we increase the yield of disparate populations, so underrepresented minorities, vulnerable patient populations, people who you might not otherwise be able to meet, that maybe they're not coming to the healthcare system, but can you meet them online and perhaps engage them in research questions? Obviously issues to think through. Anybody know what this device is? How many people have one of these? How many people have more than one? This is an amazing instrument. It's called the Amazon Echo, also known as Alexa. And this is probably if any of you have used Dragon for medical dictation, forget the voice recognition on that. This is the best voice recognition in tech right now. Google is working hard with their device to get as good as this, but this is really good from Amazon. And the first iteration of it is really about fun. It's about, I wake up in the morning, ask Alexa what the weather's going to be, play me some music, tell me a joke, did the Red Sox win last night? And we do all of that. Now imagine that you said to Alexa, Alexa, my 2-year-old toddler has a fever. And Alexa says to you, how much do they weigh? And you tell Alexa how much they weigh. And Alexa then tells you how much acetaminophen to give your child. Sounds far out there? You can actually do it. Boston Children's Hospital has partnered with Amazon to do that. Medscape now partners with Amazon to provide in the cloud simple answers to common medical questions. And now a group of us are looking at working with Google and AWS to try to put this type of technology into the workflow of what we do. The engineers think that what we can do is to have voice recognition in the room with all of us as we examine patients, that the machine learning algorithms will get sophisticated enough that they can extract a reasonable note encounter for us. They can do your billing. They can pick up things that you might not otherwise pick up. And this isn't science fiction. This is all happening now, and projects are moving ahead to try to do this. Think about this from the clinical research world, again, from a study coordinator perspective. Why do you have patients come back to you? What if when you walked into the room, Alexa knew that you were there and said, Scott, how are you feeling today? Scott told Alexa how he was feeling, and keywords get picked up to the cloud into your case report form for your clinical trial. And then Alexa said, did you take your hypertension medicines today? I've dispensed a blue one over there on the countertop through Bluetooth technology, all being done. And so that's where the world's going, and really different ways of collecting data, really different ways of collecting data. The challenge, Joe Selby points it out, Joe Selby is the executive director of PCORI, he says, how are we going to figure out how to link all of this data? That's going to be one of the big computational challenges. The data is all very disparate. How are we going to figure it out? My colleagues at Duke, for several years now, have been using probabilistic matching to create ways to link data across things, for example, of the inpatient registries or the inpatient EMR and long-term follow-up using things like the CMS database. We have no national identifying number in this country that's allowed to be used to track people, and that's in stark contrast to some of our colleagues in European countries who have a national identifier. They can track them throughout the system. So we have to think about other ways in the U.S. about how we might do that, but it's possible, at least in part, because we can link them. And it's also possible because we can now start getting continuous data from our patients. And trying to understand this continuous data is really difficult. And what we don't know, for example, for decades, we've treated people with hypertension based on what their blood pressure is when they come to see us. Or maybe we tell them to bring us a couple of blood pressure measurements from the Walgreens or the CVS or their home machine. And then you start to have the problem with, well, what does that mean if they're like all over the place? Do I average it? Do I take the median? Do I take the upper range, the lower range? Which one do I base it on? Do I look at the data much differently? And so I practice in Silicon Valley and see a really interesting group of patients, including young engineers with things like hypertension, who come to me with a database and say, here's all my blood pressures measured almost continuously over the last month. And so being good engineers, I ask them to perform some summary statistics for me, and they bring me back these great analyses, but I don't know what to do with that. Which one do I treat? And I think those are really important questions as we have more and more continuous data to know what to do about that. But here's where I think the big changes are going to come, both in clinical medicine and clinical research, including in clinical trials. And that's the concept of artificial intelligence, deep learning, and machine learning, is how are we going to utilize those tools to make our jobs better, easier, faster, more fun, more accurate, and how can we utilize the machines to actually help us do things like clinical investigation. A lot of you may have seen the series of papers in JAMA a couple months ago utilizing tools of AI and machine learning and validating algorithms to predict diabetic retinopathy. Here's my prediction. I hope, are there any radiologists in the room? Good. Radiology is going to go away. The prediction is that in 5 years we're going to need far fewer radiologists as we currently think about them, because the machine is going to be so good at doing most of the routine stuff that we're not going to need vast rooms of people sitting looking at film. The machine's going to do it for us. Now there's going to need to be a level of expertise that's going to oversee those algorithms. It's probably going to deal with the difficult cases, but it's not going to be routine. Same thing in pathology. We have a project going on now at Stanford where we're digitizing 50 years worth of slides for the whole purpose of machine learning with those slides. And my guess is that there'll be a whole new areas of biology that get brought out by understanding the digitized slide. The machine will see patterns in that the human eye has been unable to do. But you can also use this for research. Josh Knowles from our place, along with Nigam Shah, are doing a massive machine learning project trying to identify patients with familial hyperlipidemia. You probably know that it's a group of patients who are woefully undertreated with statin therapy, despite the fact that they remain quite high at risk. And the machine is learning within the Stanford data. That process is going on now. The machine will then, and the algorithms will be applied to the Penn data. And then ultimately, the refined algorithms will be applied to a national data set of about 65 million individuals, trying to understand, can we find a certain patient phenotype utilizing machine learning? And if we do that, that is good for both treatment, but also for research purposes, because now you've identified people. And if you're saying, what the heck is he talking about? AI, deep learning, machine learning. Terrific paper published about a week ago in the New Yorker that's worth reading. It's just all the basic concepts of AI, deep learning, machine learning. I keep coming back to the notion of we're going to need to randomize. one of my favorite quotes. I always get a hard time from my health services research friends. Any claim coming from an observation study about treatment is most likely to be wrong. Now, that's a fairly provocative statement, but notice that in parentheses I added about treatment comparisons. If we're going to do randomized, if we want to understand A versus B, as Greg Fonarow said, randomization, there is no substitute. We really do need to be able to compare things one against another. And the engineers have known this for a long time. How many of you use Google as your primary search engine on your computer? Did you know that any time you're on Google, on average, you are in 6 to 10 randomized experiments every time you're in your search engine? And that's and it's everything from font to positioning of ads to colors to different lighting. Everything is being tested constantly. And the reason is that the engineers realized a long time ago, guess what? Frequently their intuition was wrong. And so being good engineers, being good scientists, they decided, well, we better study it. And so Google adopted this note. They were one of the first adopters in the tech industry of continuous, they call it A-B testing, A versus B. They have factorial designs, they have adaptive study designs, and they constantly iterate on their algorithms and on their search as utilizing experiments, A versus B. And if you go to Google, you spend time with the engineers, they're always talking about A-B testing. A-B testing is a randomized trial. They're randomizing you to a different strategy. We might be interested in death, heart attack, stroke. They're interested in clicks. Where do you go to? How do I optimize that? And that's what they're constantly doing. I would tell you that having done clinical trials for a long time, we need to make ours simpler. There's only about 10 things we've determined that actually matter in a clinical trial. And if all we did in clinical trials was really focus on what really mattered, we could simplify clinical trials. Let me give you some examples of things that we're doing. Ellie Nantman and I said a few years ago that the problem with trials, and think back to that cartoon, that they became so complicated that the original simplicity was lost as they became increasingly complex. And we thought about this notion of embedding randomization directly into the electronic medical record, or embedding randomization into registries sponsored by societies like ACC and AHA. And we wrote a paper last year in JACC that talked about what are the different options of doing different kinds of trials. Well, like many things, our friends in Europe were ahead of us. And in large part, they were ahead of us because they made two societal investments. One, they decided many decades ago to have the national identifying number. So from the time you're born to the time you die, in many European countries, I'm particularly speaking of Sweden right now, you have a identifying number that you use for everything, in healthcare and outside of healthcare, and that data can all be linked. The second is that they made massive investments into disease-based registries across their country. And so for the interventionists in the room, you're familiar with like the SCAR registry, where they collect all the cath and angioplasty data across the country. And that led to this notion that they could do randomized trials within their registry. And so the first trial they did was something called TASTE. TASTE was a trial that embedded into their QI registry randomization to thrombectomy or no thrombectomy at the time of ST elevation primary angioplasty. They enrolled about 7,000 to 8,000 patients over the course of 2 years in Sweden. That was just under 70% of all the MIs in Sweden in those 2 years. That's extraordinary. That's generalizability. That's big scale. It cost them about $300,000 US because all they did was lay it on to something they were already doing. Contrast that to some of the prices I've told you. We've talked about this through the ACC, and could we do this through our registries? And in fact, we have tried to do this through the ACC's NCDR, but we have huge limitations relative to our Swedish friends. Number one, we don't collect all the data that needs to be collected through the NCDR, and the people that work in the cath lab know that. Number two, follow-up stops at the time of discharge from the hospital. And number three is that it's not done in real time. The Swedish registry is in real time. When you're having your heart attack, your data is going right into the registry as part of the process of collecting information on you. As you know, within NCDR, that data is batched and sent in periodically. And so there's a lot of limitations to it that need to be overcome. Well, one of the ways that it can be overcome is going to a place that does have a more unified electronic health record. How many of you here work in a VA? So the VA gets a lot of knocks on it for its EMR, but in fact, it's really the only true interoperable EMR in the United States. If you are a patient in Boston, then you become a patient in San Francisco, your data's all there. And so the VA is really leading the charge to embed randomized clinical trials into the point of care. This is one of the, they've done some small pilot ones. This is the first large-scale one that they're doing. Almost 14,000 patients, point of care randomization, so right into the EMR, all the follow-up done through the VA EMR, including the pharmacy, and they're going to test that burning question of 2 different diuretics for treatment of hypertension. You'd say, well, why are they doing that? Well, all of the data from the clinical trials with clothianidone in terms of it's shown its benefits, but what do we all use in clinical practice? Hydrochlorothiazide. And so it's a really practical question that can be answered here. And look at what they estimate the cost is here. In the VA system, to participate in SPRINT costs them about $15,000 per patient. They think that this trial is going to cost them $700 per patient. And so this is the new way of doing clinical trials, but you have to have data systems that support this. We don't generally, but PCORI has made an enormous contribution nationally, spending a couple $100 million to create something called PCORnet, which are large systems that have bonded together, that have aligned together, and have agreed to exchange their data and put their data into a common data model for research purposes. And so we're doing the first clinical trial with PCORnet, large-scale clinical trial called Adaptable. And look at some of the figures here. We already have something like 500,000 individuals pre-qualified for randomization into the study. It'll ultimately randomize about 20,000 patients over 24 months at 30 sites. And again, like the diuretic question, one of those burning questions, aspirin dose. Is it better to take 81 milligrams of aspirin or 325? We actually don't know the answer to that. And in fact, if you look at us as a country, about half of us use 81 milligrams and about half of us use 325. Well, actually, it's about 45, and then 10% use something else, like really high doses of aspirin or really low doses of aspirin. But there's complete community equipoise. In fact, we've tried to understand, is there any rhyme or reason to who's getting low-dose aspirin or high-dose aspirin? Maybe doctors are just making smart choices. We can't determine that. We don't believe so. This is how the trial is organized. I had the privilege of being one of the study chairs along with Russ Altman from, Russell from Vanderbilt, Russell Rothman. And the reason I put this here up, though, is in the red box. This is the first clinical trial, large-scale clinical trial I've ever done, where we have patients on the protocol committee, patients on our executive committee, and patients on our independent data safety monitoring committee. The patients are really engaged in this, providing us counsel and insight along the way. As I said, the simple trial, aspirin 81 versus 325, prevent heart attacks, cause bleeding. We find the patients using something called a computable phenotype to get placed on top of those that common data model through the electronic health records. We've identified well in excess of 500,000 patients. We've made consent easy to do over the web with an avatar walking you through the consent process. You can do it at your own speed. And we're also doing some things to, what I would say, collect data in a more traditional way to make sure that this way is acceptable, including using phone follow-up for certain individuals. The trial's really different than a standard trial. And I like to use this because this is when we launched the trial in October in Washington, D.C. There's a picture of the study group in the first row were all of our patients who were involved with the study. So these are people who have had bypass surgery, people who have family members who have had angioplasty, coronary disease, heart attacks, very, very engaged in the process. You can follow it on the Adaptable Twitter site. And as I always point out to people, we can do this. We did it back in the 50s when we needed to solve the polio question. And in 2 polio seasons in the United States, more than 1 million children were randomized in very innovative trial designs, including cluster randomized trials across the United States. It was an important question. that had devastating consequences to it, and we were able to figure it out over the course of about 2 years. Remarkable. We ought to be able to do this again. Well, I'll close with just 2 things I want you to think about. One of which is, if we're going to do research this way, does the current ethical construct we have support that? And this is a statement taken from a group of bioethicists at Johns Hopkins University that I think is pretty provocative, requiring that all activities that are designated to produce generalizable knowledge and that collect data systematically must undergo prior review, even when patients' clinical care is in no respect changed, is a misplaced moral criterion of what needs review and is a deep weakness in our current system. That's a very profound statement. She's basically saying, you know, are we doing everything wrong? And that should we have a very different way of thinking about things like consent? Finally, sharing data is going to become increasingly important. Some interesting work continuing to come out on the benefits as well as the risks of data sharing. And so I'll end here, where I hope that I've shown you what some of the demands are for evidence, some of the things, the limitations of standard trials, and some of the new ways of doing things, including giving some examples of some of the things that we've been involved with. And for those of you who have not visited us, please do come. That's our medical school that's lit up in our main university. And I'm really pleased to be here, and thank you very much. It's an honor to give this. Thank you.
Thank you very much. Excuse me. There's a world famous statistician named Don Barry who was here at the University of Minnesota and then Duke and now Houston, and he's an advocate of what he calls Bayesian clinical trials. Is there a role to that?
Yeah, so I know Don. He's also a big advocate of adaptive trials, learning as you go. So fundamentally, what he would promote is, I would say, 2 notions. One of which is, let's consider all the information that you already know about a topic and incorporate that into how we think about the trial going forward. That would be the Bayesian approach. Contrast that to the frequentist approach, where, no, the only truth resides within the box that is that current experiment. Clinicians by nature, we're Bayesians, right? We consider the totality of the information when we're making decisions. And so I think Bayesian approaches have a lot of, there's a lot to like for clinical people. It's interesting, in the drug world, so the evaluation of medical therapeutics, in the drug world, Bayesian statistics are used, I would say, infrequently, probably too infrequently. In the device world, they're actually used quite frequently. And at the FDA, there's even preference given to some of the Bayesian analyses. Dr. Barry also talks about adaptive trial design, changing the trial as you go. And that's, in some ways, what the engineers do, is that they're constantly iterating, and as they get information, say, about a strategy, and that looks inferior, they'll drop that strategy and replace it with something else and keep going. So yeah, I think there's a lot to learn from other areas, and both Bayesian approaches and adaptive approaches are worthwhile to think about. He's a really smart guy, by the way. Yeah. Yeah, Tim.
Outstanding, and really brings up tons of really important issues. But can you expand a little bit more about the IRB and the ethics of being involved in this? You know, from my perspective, it's shocking, the variation on how institutions interpret this across the country, and how do we get to a more uniform and rational way of doing IRBs? I'd like to know your thoughts, because, you know, we do Medicare data, and there's tons of trials on that. There's tons of trials on NCDR, and individual patients don't sign consent for all those, and we publish those every week, yeah? Yet certain institutions have very strict uses on how, like, they can't use their own NCDR data because there's no IRBs. So how do we do this more rational?
Yeah, so if you read, you should pull out Ruth McFadden's work, where she really does a deep dive into a lot of the questions you're asked, but I'll say a couple things, Tim. First off, this notion that when you're doing a large multi-center randomized clinical trial, that you should have 400 separate IRBs review it is absolutely ridiculous. And so the new common rule, which is going to say for federally sponsored projects that are multi-center, one IRB, one central IRB to handle that. And I think it will only be a short period of time before we can push other types of trials into that. And so for multi-center clinical investigation, I think you're going to see a lot more efficient conduct. what actually has to be reviewed is what she's asking. So, for example, there was intense debate in the VA system of whether or not they should even get consent. Here's two drugs that they're widely using. Nobody knows which one's better. Why would you let a doctor pick one for his or her patient when there's no reason to believe that they're picking it for any rational set of reasons? Why not randomize them and allow the data to at least be usefully collected? That's the moral dilemma. And so there was intense arguments in the VA system, and those of us who would push not to have it reviewed lost that argument. I made the same argument adaptable. I said, why are we asking for consent? That this is what people are doing, and there's no rhyme or reason to it. That's community equipoise. Society has a way to go. I don't know if you remember the HEAT PCI trial, where they were using bivalirudin or heparin in primary angioplasty, and they randomized people with an ST elevation MI, and then after the procedure was over, they told the patient that they had randomized them. They got consent, if you would, afterwards for the continued collection of their data, but they never got consent for the actual administration up front. And there was a lot of controversy as to whether that was okay. To tell you how emotional it is, I debated Bill O'Neill on this topic. And so I gave this big ethical argument about why that was a good thing to do. And he gets up to follow me, and the first slide he puts up is from Tuskegee. And so it's not the same, but that's the level of emotion that you're going to deal with as you try to change these things.
First of all, I really like your talk about how we could do randomized controlled trials differently, cheaper, and simpler. I mean, I think that's incredibly important. But I get a little nervous when we talk about taking data and making generalizations. And the more you make this thing broader, I think you have the potential to make some bad conclusions. And so that makes me nervous. And then the other thing is when you talk about machine learning and algorithms, I think my understanding is that they still aren't very good when it comes to the context of the problem. And contextual component is huge, and that's the big problem with all these algorithms. They're not contextual. And so I think, I mean, I like your enthusiasm, but I think we have to, you know, I'd like you to at least just address those two concerns.
Yeah, let me take the second one first. I totally agree with you. And one of the reasons, I don't know if you're here when I made my radiology comment, I think that the machine's going to get as good as the radiologist for pointing out the abnormalities or lack of abnormalities on an image. In fact, the machine will get better, I guarantee you, and more predictable and more consistent. Now, context. You're absolutely right. I didn't say there's going to be lesser need for internists, cardiologists, neurologists, orthopedic surgeons, because it's going to be that professional that provides the context. But if what your life is reading images, whether they're skin lesions or CTs, that is going to go away largely, because the machine's going to be better than we ever could be. And but there's going to be, pick a number, 20% of cases, something that the machine struggles with. And then we're going to need the high-level expert to at least make some inference about what that is. So I didn't want to, I should probably qualify it. I think context is really important, and that's why clinical people who have the context of sitting with the patient, of examining them, of putting it into the totality of everything that's been collected, that's going to be your job. And I actually think that's a much more fun job than, you know, sitting there for a half hour trying to figure out what am I seeing on the film. The machine will tell us what you're seeing on the film, and they'll get better and better at it. So sorry about the confusion. And then your first question was the mass of data. This gets into this whole notion of being precise and being accurate. And they're not, and as you, I think your question indicates, they're not the same thing. And again, I think this is where context, and you can't just have, I think we have a biostatistician over here. You can't just have a biostatistician giving you the numbers. There's context there that you have to put it in. And one of the reasons I really, when you're talking about therapy, you know, there's a big push. People think, well, if we just data mine it on everybody, we can tell you what the best dose of aspirin is. You can't. And that's where the power of randomization comes in. And you're going to have to randomize. So two good questions. Yeah, Jay.
Bob, thanks so much. I was thinking about, dear to my heart is the increasing difficulty of doing ischemia reperfusion injury research in the United States. compared to Europe. In the past, we could do a verbal consent followed by full informed consent 24 hours later, and all the data says the patient can't comprehend a 15-page consent form while he's having a heart attack, yet they make us do that. And I'm just wondering, do you see any movement at the federal level of maybe getting more towards Europe, where they have like an ethics committee that sort of allows you to do that kind of abbreviated process? Because just like devices are way ahead in Europe, it's the same thing that's going to happen with research. We can't do some trials now because of our whole consent process.
Yeah, I think the common rule changes are going to actually, this is an area, so there's some things in the common rule I think which are going to be problematic, but this particular one I think is actually going to help. So having a single IRB that will oversee multi-center experiences is going to take away some of the willy-nilliness of individual IRBs that force us to do certain things. Secondly, the FDA is very interested in a lot of the research that's being done by the ethics communities about the best way to get informed consent. But these are heated conversations right now. We have a group at Stanford led by David Magnus who are doing very sophisticated work in how does one communicate risk to individuals, and utilizing things like cartoon pictures and videos, but trying to really simplify informed consent so it's not 15 pages of jargon. I was at an FDA meeting on Friday in Washington about patient recruitment into clinical trials, and there was a panel with two patients on it. One was a young gentleman with cystic fibrosis. The other was a middle-aged gentleman with heart failure. And the differences in their experience were extraordinary. And one of the big differences is that when you have a community of advocacy, et cetera, like in CF, the processes are so much better and streamlined and simpler because it's all encouraged about getting the bar to move in CF. And heart failure, here's the most depressing thing I heard that day. This patient, the young man who was in his 20s said that he'd been in clinical trials since he'd been about 5. The middle-aged guy said, I've had heart failure for 24 years. Nobody approached me about research until year 22. We don't have the same community in cardiology as they have in CF, and I think that's going to be part of the issue. And that's why getting our patients involved is so important. They're pushing us to say, answer these questions and don't do it in stupid ways. So I think people are listening. And we just, and all of us have to be, you know, out there having these conversations, and, you know, with FDA, with pharma, with NIH, et cetera. Yes. Okay, Steve.
Hey. So thank you for an excellent talk, and it's wonderful to hear this. I've had the opportunity to hear this before in Denver when you visited, but you spoke about the challenges ethically of what's needed to inform patients and the challenges of creating data structures to capture this in routine care. One of the challenges you've kind of alluded to, but I'd like to hear you expand upon, is the challenge of engaging the physician so that hubris of the physician about we know best for the individual patient doesn't prevent randomization to inform these questions.
Yeah, so much better answers than I are given by the folks from Hopkins, because that's essentially what they're arguing, is that we let people choose randomly, non-systematically randomly, and we call that the practice of medicine, and we don't learn from it, right? And so how do we really force people into an environment whereby systematic learning is not just encouraged, it's mandated? So here's the world I want to live in. The world I want to live in is that when the answer is known, the system that I work in makes sure that I do it. And when the answer is not known, which is most of what we do, the system that I live in enforces learning of that. So one of the things we're starting to do at Stanford, for example, is I'm deploying all these young clinical informaticians around the healthcare system, and I think you should randomize everything that you don't know the answer to. And so that's my starting point. And so we are doing some things. We're forcing them to, before we roll out best practice alerts, actually doing randomized trials of, do they actually work? Do they help? Do patients get better care? I think that's the kind of systems we want to get to. And I'm hopeful because the new generation has less hubris than our generation. They understand this stuff.
Any more questions? Thank you all very much. Have a great day.
Thank you so much. Thank you for having me.